Thank you for joining us on a very hot afternoon to discuss health of the elderly in India. Uh, as you know, ORF Fellows Seminar Series is a platform where we share our research outputs with the broader research community. And today we'll be discussing a recent paper written by our colleagues Mona and Dr. Shoba Suri on NCD prevalence among elderly women in India. And we are lucky to have with us two esteemed public health experts who have between them many decades of experience to discuss this paper. Professor Monika Arora is Vice President, Research and Health Promotion at the Public Health Foundation of India. Dr. Rajiv Tandon has been Director till very recently of Health at RTI International India. And both these experts have been part of many important initiatives and very esteemed international as well as national institutions which have driven nutrition and health policy in India. We hope to learn from you, ma'am, sir. And before I hand it over to my colleagues, I will just try to give a very brief backdrop. We know that India is right now the most populous country in the world. India, in fact, overtook China in 2023. But India is not yet the country with the most number of women in the world. That is still China. China, many of us would know that China also has a very adverse sex ratio. But still, China's total number of women is higher than India. In fact, India became the country with the highest number of men in 2022. So there was a lag between the total population becoming the highest and the male population becoming the highest. So now I think between 2025 and 2026, India will become the country with the highest number of women in the world. So the logic, the underlying factor behind this is, as you all know, many complex social factors and cultural norms around sun preference and many factors that mediate access to services, life chances, and even livelihoods in many contexts. So it is in this context that women's health has to be discussed in health policy in India and broadly at a South Asian context. Thankfully, access to health services has been discussed over the last decade or so with a gender point of view. In AIMS, very close to here, 2 million or so outpatient visits were studied about 3 years back, 2018. So for every one woman who visited outpatients department in AIMS, 1.7 men, that is a 70% difference in access. So, and that study itself again found that as distance to the care provider increases, that gaps goes wider. For example, from Delhi, more women patients were accessing AIMS. For example, Bihar, For every woman patient, around 3 men patients were coming to AIMS. That is public healthcare delivery. In insurance access also, we at ORF had done some analysis of insurance data about 5-6 years back. So looking at data from 2014-15, we realized that although insurance enrollment is equal between men and women, the claims and the money given are at a proportion of 70-30, 70 for men and 30 for women. And in recent health insurance schemes, PMJY, for example, the claims are 50-50, round about 50-50 between men and women. But if one removes childbirth related services, then it becomes 42-58 or something around that. So access is something, access to women is something that India is working on, India needs to work on. So that is the context where we present this study, which finds that NCD prevalence is higher among elderly women. So India is going through a demographic transition. So NCDs in general are putting pressure on our existing healthcare delivery systems. And this complex situation where access to women is mediated by various societal and cultural factors, this is going to be a daunting policy challenge, and I look forward to today's discussion. Before I move on to my colleagues for their presentation, just a plan of today's program. First, the paper will be presented for about 25-30 minutes, and then our esteemed panelists will give their take on the paper, 10-12 minutes each, and then we will have an open house question answers for about half an hour. That is how we have planned the session. Now over to my colleagues Mona and Dr. Shoba Suri.
Thank you, Oman, for setting the context, and good afternoon, everybody. And thank you for joining us for this very important discussion, especially when we talk about gender and also the non-communicable diseases. So I think it's an issue of concern and needs to be discussed. And here we will be presenting a paper done by Mona and myself on the gendered prevalence of non-communicable diseases in India's elderly women or older adults, as we have the definition, go by the definition. And here we have studied the data from the LASI phase 1, which is the longitudinal aging study of India. And there are a few analysis papers in the domain on the LASI data. But what makes this different is we have conceptualized this based on elderly women. We have taken data for elderly women, plus the non-communicable diseases and the risk factors associated. So we have specified ourselves to the data on the elderly women and the non-communicable diseases. That was Mona's idea to study this further. So, okay, sorry. Just to give you a brief background, Oman has already mentioned this, but yeah, there has been advancement in medical infrastructure as well as the falling fertility rate. India's elderly population is rising, and both there has been a demographic and an epidemiological shift, which has shown a gendered impact. Women's health have historically been under-prioritized, and there has been a disproportionate volume when it comes to elderly illiterate or in terms of financially uninsured and progressively diseased population. We have about, in 2021, it was projected that we have about 138 million elderly people. And out of that, 71 million were women and the rest men. Further, the share of the elderly with respect to the overall population has been steadily rising since 1961, as you can see on the infographic. Wherein the male population has risen from 5.5% to 9.6%. On the other hand, the female, it has gone up from 10.7 to from 5.8 in 1961. And it has also been projected by 2031, the share of the elderly is going to rise to almost 13%. And a recent report suggests that by 2050, it is almost going to be 19.5% of the population. The UN General Assembly also had declared in 2021-2030, in the decade of healthy aging, there was a call for a global collaboration to improving the lives of the elderly population. The recent election manifesto, this is just a 6-day-old news, wherein the manifesto also suggests that the Ayushman Bharat should focus on the senior citizens to be able to cover them for an insurance. So I think this is an important issue and an area of concern, and needs to be discussed, and we should see how there could be a way forward on this. 18% of almost the 45 plus year population and almost 23% of the 60 plus have been diagnosed with multiple morbidities, including non-communicable diseases. Non-communicable diseases, on one hand, we know that they are of long duration, and they are a result due to a combination of genetic, physiological, environmental, and behavioral factors. Especially non-communicable diseases among women are again a result of multiplicity of external factors, among which social determinants of health, be it income, social protection, unemployment, education, they play a major role when it comes to the prevalence of NCDs in women. Also, some of the health risk behaviors like alcohol consumption and biological factors, they play a role. Why do we need to focus? Why is there is a need to focus on women? Because they have been disadvantaged by both social expectations and responsibilities traditionally. Like when we say that, for example, when we say that older women bear a disproportionate amount of unpaid care work, evidence shows that almost elderly women, they spend about 245 minutes a day as compared to 112 minutes for the elderly men in terms of unpaid work, care work. They are also often segregated in poorly paid, labor-intensive work, and they also have poor access to digital tools and technology. And unfortunately, they are also at the risk of gender-based violence. And it has also been seen that they are dependent on their children for the living arrangement, and which is significantly higher for women, almost 25%, as compared to almost 9% in men. This could also be explained due to the lower economic status and lower wealth accumulated by women when we talk about women's agency and empowerment in their lifetime. Men across all states in India, the data shows that they live with support from their spouses and children. COVID has had a terrible impact, specifically when we talk about people having pre-existing comorbidities. They have been severely impacted. When we see India's first wave of COVID, it showed a very high mortality risk among the older population, 60 plus, especially with pre-existing comorbidities, where NCDs, I think, played a very important role. Nearly 70% of the elderly population, they depend on others for their day-to-day needs, as per the NSS survey of the 2017-18. Also, it's been seen that among the 60 plus older adults, the prevalence of heart diseases is higher, especially among women. It's been found to be 7% and somewhere around 5% when we talk about men. Also, the same is the case with high blood pressure, wherein you see more women, 38% around, are impacted than about 33% or 34% of men. Also, this shows that the burden of any undiagnosed heart condition is more likely to be seen higher in women. This we are basically talking about women in India. We're looking at the data from India. And also, it's been seen that the incidence of morbidities and multimorbidities, they are progressive as the age progresses. Also, during the COVID, there was high level of vaccine hesitancy, which was noted to be more among the elderly women. Especially, we have seen cases in Tamil Nadu, and this has been quite talked about. So we looked at the various studies of evidences which were already there, talking about the socio-demographic and the risk factors of NCDs in elderly women, and also generally how it's more impacts women than men. We also looked at studies wherein they had done on 45 plus age category. Both in developing countries as well as developed nations, it was seen that the gender gap in self-rated health among the elderly women was quite evident. And the proportion of elderly women rating their health poorly was higher than the elderly men. As I mentioned earlier, that the prevalence of diabetes, hypertension increased with age among both men and women. But this was higher in case of women when they had associated risk of obesity, osteoporosis, and dyslipidemia, which was seen more among women. Various studies, existing studies on elderly women in India have shown that the prevalence of diabetes and cancer increases with age. It has also been seen in the case of anemia. It's been progressive, though anemia in children and women of the reproductive age is also quite high, but then it progresses, and in elderly women, it is also seen a high prevalence has been seen. We also looked at some of the studies from the other region, and it was found that the co-occurrence of multiple comorbidities, risk factors like drinking, smoking, physical inactivity, and poor intake of vitamins and minerals were more prevalent among women than in men. A study by WHO also found that the percentage of adult women with inadequate physical activity is higher in adult women, and this is reversed in the case of smoking and alcohol consumption. So, in which the gender gap is much more significant. Again, there has been a gender gap when we talk about the wealth quintile. People with highest wealth group, those age 70 and above, and especially women and tobacco users, had a higher likelihood of NCD multimorbidity. Also, equally important role is played by the presence or absence of social protection measures, specifically in affecting the NCDs and the health outcome among elderly women. Later in the slides, Mona will explain more, talk about the social protection and the insurance schemes. So with this backdrop, the idea to put together this paper was to study the literature review and whatever emerged from the lack of adequate evidence to have a policy-driven case, especially in terms of for the elderly women. And the focus was also looking at achieving the SDG 3 and SDG 5, and specifically when we talk about SDG 3 on good health and well-being, when we look at the sub-indicator of 3.4, which talks about reduction of 1/3 premature mortality from NCDs through prevention and treatment, and to also look at 3.8 of achieving the universal health coverage by reducing the risk protection and the risk factors. So this study, we were trying to look at collating the data from the LASI, analyzing it to see what policy action could be derived from it. And so in this paper, we have tried to look at the existing literature and also establishing the link between the social determinants of health and the gendered prevalence of NCDs in order to determine the increased burden of NCDs in this age category. And the data has been taken from LASI, as I mentioned earlier. This is, I think the survey happened in 2017-18, and the report was out somewhere in 2020. And this is the phase 1 of the data. And further, we also look at some of the risk factors like education, some of the risk factors like, the health risk like tobacco and smoking, plus education, the familial support, the work engagement, and the social protection. So the main objective for this paper was to highlight the gap from the existing literature and to have a policy-driven case to strengthen the gender and the age-responsive health system, especially in the case of older women. So the methodology, as I already explained earlier, we do have the NSS and the census, which looks at the demographic data, but an holistic understanding of the age-segregated data was not available, which we could find in the LASI. So that is why we took up the LASI data to understand this. And so there was not a comparison which could be done with any other data because the data sets were not comparable, especially the NSS and also the NFHS, which does talk about 45 plus. But here we are specifically looking at the 60 plus elderly, older adults category. And also, this is again the pre-COVID data. So this does not reflect any impact of the COVID on the pandemic on this. And also, this is a self-reported data. LASI data set is a self-reported data set from a large-scale survey, which also diagnosed NCDs wherever, are not available. So that's in brief of a background of why the study. And now I hand it over to Mona to talk to us about the evidence from the emerging data and the existing literature.
So now that we have established how India is aging and the fact that non-communicable diseases are raging, so we will now step into what the LASI data sets discusses in detail with respect to the literature that is already present. So to begin with, we have here a graph showing that post the age of 45, the growth in major chronic health conditions in India increases significantly. And this is significant, especially for, let's look at hypertension and cardiovascular diseases, one of the leading causes of death in India as well. Moving forward, this is the self-reported prevalence of the chronic health conditions that we'll be particularly discussing. We can see that the highest here is with the cardiovascular diseases, which is at 34.6. We have hypertension, we have bone and joint diseases, and we have diabetes mellitus. In addition to the top 4, we are also discussing anemia, which we'll be looking at in more detail in the further slides. So when we look at the LASI data at a glance, we very clearly see that this prevalence is gendered. Except for diabetes here, we see that cardiovascular diseases, it's 29.2% for females compared to only 25.6% for males. There's similar difference in anemia, hypertension, and bone and joint diseases. So delving deep into cardiovascular diseases, we see that there is a general trend that women have a higher prevalence of cardiovascular diseases. When we look at it subnationally, the rate among elderly male was higher in states of Kerala, Goa, and Andaman and Nicobar Islands than in other states like Chhattisgarh and Meghalaya, which have an opposite trend. The gender distribution was near equal in states like Andhra Pradesh, Delhi, Jharkhand, and Tamil Nadu. Moving on to anemia. Anemia, we know that the general trend is very distinctly skewed towards women. We know that 5.9% of women compared to only 3% of men among the elderly are anemic. And across all states, this trend is very clear. And what is important to note here is that we know that from NFHS 5 that 57% of women in the reproductive age and 60% of adolescent girls are anemic in this country. So what we need to focus here is the urgent need to tackle the situation of anemia early on in women's lives. Elderly women are more susceptible to severe long-term impacts of anemia compared to younger demographics, which later in life significantly also is responsible for lowering their quality of life. When we look at hypertension, the data suggests that 1 in every 3 senior citizens in this country have been diagnosed with hypertension. And the prevalence is higher among women following the same trend, which is at 27.8%, rather than in men, which is at 22%. We look at the subnational trends here, which shows that Chandigarh had the highest percentage of elderly women with hypertension, followed by states like Jammu and Kashmir, Haryana, Punjab, Kerala, and Goa. Now, diabetes was an anomaly in the overall trend because the prevalence was not distinctly gendered. Of course, it was higher among men. But the reason that we chose to talk about it is from the consequences that it has on women's health. Research has shown that diabetes in women results in almost 4 times higher risk of heart diseases, which is only 2 times higher in men. Similarly, it also causes more likelihood of worse outcomes during a heart attack. In the same trend, we look at mortality because of cardiovascular diseases emerging from diabetes. Again, the data says it's 4.9% higher in women compared to only 2.1% in men. More so, cardiovascular diseases usually present almost 10 years later in women following the general trend. But in the presence of diabetes, this gap is almost fully offset. This also holds true for myocardial infarctions, where they occur much earlier among women with diabetes. And a very important thing to note here is the fact that we know that the risk factors for diabetes, such as psychosocial stress, obesity, and depression, they are more prevalent conditions among elderly women than in men. Hence, it becomes all the more necessary that we focus on diabetes in line with other trends where women in general have higher prevalence. Looking at bone and joint diseases, the LASI data tells us that osteoporosis, which is only 0.9% in men, is 1% in women. Arthritis, 9.9% in women, but 7% in men. Similar trend in bone and joint diseases overall, which is 16.9% in women and only 12.3% in men. Plus, we also know the data shows us that the prevalence of chronic pains, the likelihood of having injuries, and the likelihood of being hospitalized because of falls and lack of mobility is higher among women, especially for urban women. So we see these are also prevalent. So when we look at it subnationally, the highest prevalence was seen in West Bengal, followed by states like Jammu and Kashmir, Kerala, Daman, and Telangana. The lowest was in Manipur and Meghalaya at 3%. So now now that we have looked at these diseases in depth at subnational levels. Now we'll look at them with respect to the social determinants of health, which Dr. Suri has already spoken to us about. So in risk factors, we have taken tobacco, consumption of tobacco, another is smoking, and the third one is heavy drinking, all of which are very clearly skewed towards males. Right, we know that almost all lifestyle related risk factors, the occurrence of non-communicable diseases are dependent on these three very critical risk factors. These are responsible for metabolic and psychological changes, elevated blood pressure, obesity, elevated blood glucose levels, elevated cholesterol, all of which are just the beginning of new non-communicable diseases. Looking at education, we know, and we have classified this across 4 categories, starting from no schooling, which is highest among females. And this is also carried forward across the life cycle of a woman. Looking at less than 5 years of schooling, of course, the percentage is lower for women. Same with 5 to 9 years and more than 10 years of schooling. We know that global data suggests that gender differences in health status among elderly can be attributed to various levels of education, among other factors, of course. The prevalence of diabetes, heart diseases, stroke, hypertension, and cancer have actually been studied, that the prevalence can be decreased through higher educational attainment. In India also, India also mirrors this similar trend with global situation, where elderly women with higher levels of education are associated with lower prevalence of NCDs, owing to greater awareness about preventive measures and dietary requirements. Poor overall literacy, we know that may correlate to lower health literacy as well. Now, looking at familial support, it basically delves into the living arrangements of the elderly in the country. So, one striking number here is living alone, which is 4.5% for women and only 1.8% for men. We know that for a fact that social networks and family play a significant role in disease management, especially for non-communicable diseases like diabetes, hypertension, and others, ensuring adherence to medication, better detection, and better behavior management, and primary prevention of the NCDs very early on in life. Global studies have looked into sense of companionship, good relationship with spouse, perceived safety at home, and a supportive social network are very vital for enhancing the life satisfaction. These are also very important factors when people rate their health. The self-rated health outcomes are higher among people who have these support systems at place. Now we look at LASI data, we see that living with spouse and children not only improves life satisfaction, but also self-rated health, like we discussed. But the data is skewed towards women, as we can see again here. Also, the dependency on children for living arrangements is significantly higher for women at 24% compared to only 8.6% for men. The discrepancy in the numbers is huge, and it calls for more than a health system intervention, a social intervention at this point. It signals to a larger problem at hand. Now we look at work and social protection. While these are in different slides, but we'll be these are very interconnected topics, so we'll be discussing together. So we have established that engagement in economic activities has a positive impact on the economic and social well-being, starting from very early on to later in life. And when we look at employment and labor, we know that certain spaces of employment are gendered. And there is an existing linkage between the nature of occupation and the burden of NCDs among elderly women in these sectors. So the categories here, agriculture and allied activities, which is more unorganized as a sector, is dominated by women, which is 62.6%. Whereas businesses, markets, organized sector of employment, we see it has historically been dominated by men, and it continues to be the state even today. And when we look at work, we also look at the overall social protection that it offers. So because of the gender pay parity and the participation in certain sectors and non-participation in certain sectors, it prevents women from availing higher economic freedom. This is an example that I've put it here on the slide as well for people to note that when you look at agricultural activities, the mean monthly individual income for a man is almost 6,000 rupees, whereas for a woman, it's 3,800 rupees. Significantly, that same significant disparity exists for even non-agricultural and business activities, where it's almost 10,000 for men, but only 5,000 for women. Similarly, for organized sectors and wage and salary workers, it's 13,000 for men and only 7,000 for women. So we see that the gender pay parity not only just prevents them for economic freedom, but also decreases the quality of life and the social protection that they have later in their lives. Social protection, when we look at this, we have work-related pension schemes, provident fund, retirement from organized sector of employment, and receiving retirement pension, all of which are higher among men. The difference is when we look at the number retired from organized sector of employment, 7.4% for men and only 0.9% for women. And this is not even an old data. We are looking at 2017-18. So it's fairly recent, and it indicates how much these social determinants of health can influence the quality of a person's life. So we know that these protection schemes help in preventing catastrophic health outcomes as a consequence of high out-of-pocket expenditure. Among elderly, poor social protection among the parameters shown above potentially can be explained by, like we discussed, the lower economic status, widowhood even. We know that women have higher life expectancy, lower wealth accumulated over their lifetime. Moreover, access to employer insurance and pension schemes were available to a mere 9% of rural males. And while this number is anyway very low, it's further lower for women, which is only at 3.9%. But when we look at males, it is 41.9% males, but only 38.5% females in rural regions. So, coming to the very end of this presentation, we have some recommendations in this policy case. We recommend that targeted interventions are needed to tackle this gender inequalities within the healthcare systems. And there's a dire need to create gender and age-sensitive policies with a special focus on the needs and the use trends of elderly. We know that there is a renewed need to improving healthcare education and awareness with preventive health checkups and screenings. The workforce capacity building needs to be enhanced to be dealing with the needs of the elderly. There is a need to converge palliative care and chronic healthcare management to the healthcare systems. Again, lastly, we know that, and we've clearly established that these are separate sectors, and there is a dire need for collaboration and partnership between government agencies, non-government organizations, healthcare providers, and community-based organizations to create a holistic approach in addressing the gendered NCD prevalence among the elderly in the country. Thank you.
Thank you. Thank you, Mona and Dr. Suri, for the clear presentation. Now over to you, Professor Arora, for your intervention.
you very much for giving me the opportunity to review this paper. So thanks to ORF and thank you both the authors for an excellent presentation. So I would first want to highlight that, as the paper has mentioned, this is an area which has been overlooked, and it is an opportune time to be able to address the issue of women's health. And taking the NCD and women lens is most ideal because the determinants are beyond the health sector. So the social determinants angle that has been brought out is unique. Earlier publications have not dealt with in so much detail. So that is something that I really found as the strength in this paper. And addressing social determinant means that it becomes a multi-sectoral issue. So Ministry of Health has to work with Finance Ministry, has to work with Education Ministry, has to work with Women and Child Development and many others to be able to address all the variables that you have listed. Also important to note here is that it's not just multi-sectoral, it is a whole of government approach, which is again very important. We will not be able to address this issue which has social milieu and very cultural domination among some of the practices which are observed that contribute to women's ill health. And then coming back to NCD, which itself is a very complex issue. It is the congregation of behavioral risk factors which contributes to a single NCD, but we are now looking at multiple long-term conditions, multimorbidity, which even aggravates the situation further. So while we know that the population is now living longer, but at the same time, we also need to see that they are not having the right infrastructure. And women particularly, when we compare the longevity for women and men, we know they are living longer. Research has very clearly suggested globally and in India that they suffer from poor health in later years. And also the chronic illness period is longer when compared to men. And this is principally because of the behaviors which start very early on. So we have to adopt a life course approach when we are deciding on any intervention. Knowing that no country would be able to succeed in their health and development goals, leaving the 50% of their population, we need to address this issue. And I have a few suggestions which we have seen in our research experience. But at the same time, as I said, it is a very multidisciplinary issue. So the uniqueness that you bring to the paper is focusing on the elderly women. Again, the gender difference has still been studied, but that focus on the geriatric population and women in the elder age group, the differential impact that these women face because of financial illiteracy, digital illiteracy, as well as the factors which are, low income, social protection that you brought out, unemployment, job insecurity, housing, basic amenities, environment. So many issues you have discussed about. One issue which I didn't see in the paper and is again very important from the environmental perspective is the commercial determinants of health. We have talked a lot about the social determinants, but commercial determinants are the health harming industries which are targeting women differentially. And this starts right from, formula milk industry to sin industries which are tobacco, alcohol, because they see a huge market because they are largely non-users of these products. So that is why they would glamorize the products and show women empowerment, emancipation associated in media and promote it every possible way. So that is where we need to focus our attention as well. And looking at some of the current trends in terms of women living alone or with their having an improved health status if they are staying with spouse and children. Again, this is something we need to understand, culturally how it is different. But what I found in your paper was that whether it was north, south, east, or west, the trends were very similar. And we were always under the impression that it would be very culturally driven. But that was not the case. And here, again, I can draw attention to the Barker's intriguing theory about low birth weight babies having a higher propensity to develop type 2 diabetes and heart diseases when they reach adulthood. And now more and more research is actually establishing that it need not be mediated with their adult life obesity or hypertension. They are predisposed because of the earlier life challenges. And one of the major factor affecting the birth weight is the status of maternal nutrition. So anemia is one common risk factor for maternal nutrition, maternal mortality, and marker of overall health of the women. So which means that we will have to start targeting women right from an early age as they come into reproductive age group, as they transition into adult age and then older age. So it requires continuum of care which needs to be provided. And also continuing with the reproductive health effects, gestational diabetes is another neglected area, which again predisposes women to have NCDs later in life. So integration between the MCH programs and the NCD programs is the need of the hour and needs to be looked at from that integration lens. Another concept I would like to highlight when we talk about issues like lesser financial aid allocated to care of elderly, limited geriatric health infrastructure, and scarcity of outreach activities is the newly emerging concept of meaningful engagement of people living with NCDs. And that's primarily that we need to have women engaged in decision-making positions while health programming is being discussed, planned, executed, implemented, evaluated. We need to have women empowered to be able to participate in some of those dialogues, because that is where we would be able to get increased investments in women health. If we look at historically and even currently, all the research and even the clinical trials with dosing to be decided, mostly the participants are males. Very few trials would have female focus, and I bring in the concept of the bikini medicine, which is that the medication for women is only thought to be separate from men would be for the bikini areas, which is again a big misnomer and puts women in a very disadvantaged situation. And I think aspirin is one example. My medical colleagues here would know better that how women are actually seeing the side effects of these medications, which are tried and tested and dosed on men. And women are not largely part of these trials. It's just by their weight the dosage is decided. So coming to some of the recommendations that you have made, I completely agree with gender responsive health policy making. But something which we need more is, as I had talked about, integration of our programs. Also, universal health coverage has the capacity to reduce many of these disadvantages that women experience, and these are specially designed and implemented from a gender perspective. So Ayushman Bharat does have that potential. But in all our programs, we need to start having women-specific messages. For example, our NP-NCD program doesn't have a separate women focus, or our National Tobacco Control Program does not talk about chewing among women being so high. The prevalence of smoking is very low, but chewing is reasonably high. And because it is not talked about, it is an accepted norm. So women have never been told in our field work, when we speak to women in rural areas and we talk about tobacco cessation, they said nobody has ever even told us about it. How do we get that concept about that we have to quit tobacco? So that is where I thought it would be important that we get these ground realities in the programming of our national programs and subnational implementation. So closing women's health gap will definitely lead to large-scale improvement in the quality of women's life. There has been a recent investment case by McKinsey and World Bank, which has actually shown that investing in women's health would actually lead to economic benefit, because a large number of them are currently in the business and contributing to the economy. But further investment would only grow the economy of a country. So healthier women are key to unlock the potential for progress in every nation. And a nation's true wealth is not just in its resources, but the vibrant health of its women. Thank you.
Thank you so much, Professor Arora, for your comprehensive inputs. We hope we are able to, all of us, work together when the LASI phase 2 data is out for us to use and analyze. Over to you, Dr. Tandon, for your intervention.
Thank you. I too would like to thank the organizers for organizing this and inviting me. What I feel is, and I'll reflect on something that we had done way back in around 2007, where we started to look at just nutrition and what does evidence and issues around malnutrition, and that time it was undernutrition primarily, need to focus on for the country to have sustainable nutrition outcomes. This was a very, very multi-sectoral group. It had people from practically every facet of public, private, academia, UN, donors, and all of it. And very early in its plan of what the document should come out with, which eventually was called Leadership Agenda for Action, it was clear that girls and women throughout the life course, starting from when they were to be born, so preconception, to actually elderly, had to be focused separately. And practically a lot of what you have conveyed through looking at data from the LANCI is almost reminding me of all of those. A couple of other aspects that possibly need to be focused on is, one, when you're talking of elderly women, I don't think an elderly woman is the same in an urban area and a rural area. I don't think an elderly woman is the same in a tribal and a non-tribal area. I think, and Professor Mona highlighted the issue of climate change. Climate migrants today and COVID out-migration and in-migration clearly showed that possibly the elderly women and the impact on them across disease patterns, survival, livelihoods, if there was any component of that in that age cohort, were impacted the most. So what I feel is, you have clearly come out with some policy recommendations, but possibly we need to disaggregate each of those policy recommendations. And usually what we have done and we found it useful is there is a tool called convergent innovation. Professor Mona talked of whole of government. I think this is an issue which needs whole of society. We who feel we know enough, or the data that we feel we have looked at and then we can infer, misses out a lot of actual on-ground realities. And somehow, somewhere, a convergent, and this is a tool that comes out from the McGill University, it's a very interesting tool, could be something that ORF could look at. You can churn the same data through that, and it will show you what additionalities and where the gaps are required. The other thing that I'm reminded of is there was a time when we started with what was called maternal and child health, and we very deliberately forgot the newborn. A lot of times during the immunization environment, we started focusing on polio, and we actually started forgetting about everything else. While you are doing this, my request would be, and I know researchers would pick up a certain agenda and then go deep into it and do a great job, but look at it from the overall health systems perspective. Please do not ignore the rest of it. If you do have to, and Professor Mona highlighted, the issues of budgets. Is this area even funded through budgets out of Ministry of Health? Does it have actual line items that could benefit what we are talking of? Is using, and you have called it subnational, and what you've done is you've picked up states. For an issue which is so intersectional, so intersectoral, is state a unit worth even looking at anymore now? Will Kerala, North Kerala and South Kerala be the same? Will Uttar Pradesh be the same? And things like that. So what I feel is we also need to look at what is it at the policy level that we are talking of and recommending? But then programmatically, where do we want to actually have action? Definitely not at the state. Practically every national program today has started talking of not only district, but are talking of blocks. For the first time now, high priority blocks, aspirational blocks is something that the Niti Aayog has finally agreed. The ministries are starting to talk of it. An issue which is so, I would say, focused in its targeting. You're really talking of elderly women with NCDs, social determinants. We will have to start looking at much more behavioral sciences. We will have to start looking at, of course, supply side. By default, we start looking at everything from the supply side. But what about the demand side of it? Who has the potential to provide care, and to whom, and through which platform? I feel picking up a couple of blocks and then playing around with rural, urban, tribal, insurgent becomes much easier. It becomes much easier. And that could be a recommendation to LASI itself to somehow give us that data. NFHS has now started looking at sub-district data also. You talked of social determinants, you talked of safety nets, you talked of diseases, you talked of behaviorals. I feel looking at the legal frameworks and the role that women have in property ownerships, in financial control, in actually buying capacities at that age cohorts, decision-making capacities would decide their care acceptance, their care access, their care quality. In our diverse India, the other angle that we have to look at is religion, caste. It's not the same in all religions, it's not the same in all castes. Disease patterns are different in different religions, in different castes. It would be worthwhile looking at those. For the reproductive health and maternal health today, at least something called respectful care has arrived. I feel this is a particular age and this is a particular gendered group where what we have to focus on is respectful care provision. These are those aged people who usually are, in many families, almost written off. And somebody mentioned palliative care. How impossible is providing palliative care today in India, in an urban city like Delhi? We all know. All of us have had elderly in our families, and after a certain age, grandparents and parents, we realize, is there actually a package which really defines palliative care? What needs to be provided by whom? And does that have enough for NCDs? I don't think so. So I think that's an area which we have to look at. I saw diabetes becoming an outlier. And that's something we would love, Professor Mona, we have a champion here. On why would you feel that that was an outlier? Is there something that you can guide us? Common sense says otherwise. There is no predisposing factor that makes women better off than men. So is there something that Mona would like to comment on that? But I'll stop here. Thank you very much, and look forward to staying engaged more. Thank you.
Dr. Tandon, for your insightful inputs. Now, if Professor, you would want to respond to his comments, you can. Otherwise, we will open.
I can say is that yes, it would need further investigation, but it could be that diabetes again is a congregation of various risk factors. So we would not know whether it is only because of the eating and the physical activity behaviors, but the GDM is one area I feel that has not been well implemented. So we need to study the impact of gestational diabetes, especially when we are talking about this differential and why diabetes is an outlier.
Professor Arora, now you can ask questions directed at the authors or the panelists. Please, before you ask your question, make a brief introduction of yourself. Thank you.
Can I add something, Oman? Yeah, listening to Dr. Arora, we was recently reading the 2023 India Aging Report. That quite, is similar to this 2020 data which we have analyzed. And that also says that, just less than around 20% of the age group of 60 plus are covered under health schemes, especially the central government. So there is severe lack of, when we talk about social safety and social protection. And also the coverage is higher in men. It's about 20% in men, and only about 16% in women. And they have also found that the reason for this is low awareness among women, and also the non-affordability. I mean, because of the cost factor. So I think the recent report also reiterates from what has been said in the LASI data, and we also want to look forward to the phase 2 so that we can actually see whether there is a reversal in trends. So that's something I wanted to add here. Yeah.
Add is that we didn't discuss in the paper or in our comments also is the access to the health system because of the reasons like transportation. They are not mobile, or there are security issues. They cannot on their own go and access the health system. They have to be accompanied by somebody. So that is another disadvantage, and this would be more so in rural and tribal areas versus urban areas. Thank you.
We are now open. Yes. Can we have a mic, please?
Hi, good evening. My name is Ambika. I'm an intern at ORF. My question is specifically because we're talking about aging and women. What role does menopause play in propagating or increasing the risk of non-communicable diseases? And also, what can we do to raise more awareness about menopause? Because I think we are taught about the puberty and menstrual cycles, but perhaps not so much about menopause and the effects it has on women at that point in life. So yeah.
Take more questions now, sir, or
Whichever way. I think it should not be only menopause, but it should be sexual and reproductive health. We, by default, consider that at that age, that's an area that does not need to be looked at all. And I think what you've raised is absolutely right. So we need to actually focus on menopause, but sexual health and reproductive health in total.
Very good evening to everyone, and thanks to ORF for inviting me and giving me this opportunity to listen to a very insightful presentation. I am Dr. Shevanti Ghosh. I am the Senior Technical Advisor, South Asia for FHI 360 Alive and Thrive initiative. First of all, congratulations to the authors. And it's a pleasure hearing Professor Arora and Dr. Rajiv Tandon, whom I think I've known for now nearing 2 decades. And it's always a pleasure working with him and interacting with him. I think we have brought to the table a very important discourse. And though we have been talking about women's health, women's nutrition, women's well-being throughout the life course of the woman, somewhere, please pardon me, but I feel somewhere we have spoken about it, but really when it came to translating it into action, we have really not been looking at it in a holistic manner. It became always fragmented. And I understand that the needs were also biased towards certain very critical phases of women's life cycle, like pregnancy. And we very often, focused on maternal care. Gradually, we shifted towards preconception care. Even when we went to look into the adolescent girl's health, there was always a focus where we were looking at the reproductive potential of the woman, not the productive potential that the woman as a whole, We talk about the whole of society, whole of systems approach, but looking at the woman as a whole, not looking at her in a siloed manner. And we here in the room are also we must also acknowledge our role, that we have also often sometimes highlighted certain important aspects and wanted to move the agenda there, which was also needed. But sometimes we have lost track of the horizontal integration, because when we think of women's health, it is multi-dimensional, and the actions have to be coherent across sectors, and they have to act at different points in our life cycle. And we really do not have, even right now in our policy or programming framework, the right platforms or contacts for reaching, like whether it's early in life, there are certain very focused periods of contact, reach out, and then there are gaps when the system somehow, neither, even if it is in childhood, the girl child, some attention now in the adolescence, then again when it's the young married girls, we do miss out. Then there is focus during pregnancy, but we cannot do everything during that critical phase without intervening earlier. And then again, when the pregnancy ends, we forget. And as Dr. Tandon was saying, and you brought up that very important issue, as you reach menopause, you are just no longer important. Your reproductive potential is now no longer into play. So we do not value you as a human being to that extent that we are going to consider. And even in that story of women's health, while looking at reproductive and sexual health, we tend to forget overall aspects of our health and well-being. And so this is something that requires policy attention, and it has to be an end-to-end solution. And as we are all pointing out, the action has to be at the last mile, which is more, as I say, the first mile basically. And I think we have been talking about a number of very relevant sectors to come into play. The food system has to come into the picture when we are talking about the gender gap in nutrition and in health. What are women eating? We are now just looking at what they're eating during pregnancy. We are all the factors, the socio-cultural, economic determinants or commercial determinants that we spoke so correctly of, it influences the food system and the food environment for the elderly, including her own agency around the access. So that's something becoming even more critical in the context of the climate crisis. So I think that element, if can be upfront brought up to understand the diet, because when we talk about NCD, we have to look at the diet very much so, and not just during this phase, because Dr. Arora brought up a very important issue, the development origin of health. While we work on elderly and NCDs, we are forgetting the early life interventions, or even when things are happening during the conception and how it influences the NCD outcomes later on. And even when I talk about food system, the first food system matters. Breastfeeding is not only for the infant's health and well-being, it protects the mother against certain NCDs, whether it is breast or ovarian cancer or type 2 diabetes. And in our discussion, while we focus on maternal health, I am so glad that Professor Arora brought it up, that integration of maternal nutrition and particularly GDM and the risks that these women later on have for developing type 2 diabetes. not very well documented or understood, and we are seeing diabetes as an outlier. So I think, we need to take into account, I think we are all here more of the converted people, and I think our system needs to undergo lot of sensitization and responsiveness to use the equity lens, to use the gender lens, and to really deliver on what we say, what Dr. Tandon talking about as respectful care. And they are all very interconnected. It's not easy when we talk about multi-sectoral actions. There is always passing the buck happening. Don't mind me saying things which are a bit kind of hard hitting, but I think probably we need to combine the policy actions with actions right at the last mile, or rather at the first mile, to make things happen. And I look forward to remain engaged with this group on this important issue, and I'll be happy to share a report that FHI 360 have brought out globally, and India was one of the countries which contributed to this action agenda. It is called Closing the Gender Gap in Nutrition, but it looks at an integrated approach: health, nutrition, social protection, food system, and a gender transformative approach as the binding factor across all sectoral actions. So I'll be happy to share with the group, and we can see how we can bring together all these different elements together for more meaningful action on ground. Thanks so much once again.
Thank you, Dr. Ghosh. Ms. Pallavi Gupta first, and then the gentleman at the back. Can you please move to the front, sir? Pallavi.
Good evening, everyone. I'm Pallavi Gupta. I work with the Health Systems Transformation Platform as the specialist for health systems governance. So like everybody else, I also thoroughly enjoyed the presentation and the learnings. And we have also looked at the LASI data in another context. I'll come to that. Just to highlight a couple of things that stood out for me in the presentation. So I don't have questions, I'm just adding on to the discussion. So one is about the self-reported data. As you said, LASI is self-reported. In fact, studies have shown that when clinically diagnosed, the prevalence is even higher as compared to self-reported. So in that sense, the data that we have is also very positive. And then coming to anemia, while we're talking of life cycle approach and we've been looking at it, but I think whatever has happened and things will change, but we also need to look at anemia in older women as it exists today. We need to talk of interventions to address anemia in women, in older women as it stands, because they already have it. And now, do we have programs that address anemia in older women? We usually talk of adolescents and lactating women and expecting mothers, which is of course important, not to take away from that. Another interesting aspect is mentioned about agriculture and allied sector, where women are employed more than men. And if one were to look at the ownership of land, then one will find that the ownership is less with women than with men, but women are working more than men as in the sector. Another interesting thing which I add to what you mentioned about the pension for older men have more pension, as you mentioned. And we know in India, wives are usually younger than husbands, so they do spend the later years of their lives alone without their husbands. And in which case, the proportion of pension reduces once the husband dies from the government. Although pension as a scheme itself is now weaning out from the government system, but to the extent that it exists, the proportion reduces. And so the wife who's left alone gets lesser money than she was getting when the husband was around, which again is difficult for her, someone who's not been earning, does not have any possessions, any wealth, for her to then survive on reduced income. And I'll close with just relating with some of the work that we have done. So we looked at it from the angle of care providers, and this whole thing started when we looked at home health care. Actually, we started looking at regulations related to care delivery, and we realized home health care is one sector which is really expanding, coming in, especially with the private home healthcare companies. And so there are care providers, there are agencies training them. And while I was not myself aware of it, honestly, but when we got down into the when we got down into doing the study, we realized that home health care and care providers are mostly tending to the needs of the elderly. We started out with healthcare at home, providing healthcare interventions at home. How can that address the caring needs? How can that reduce pressures on hospitals? But we realized there's a social care need and there's a health care need. And it's often a continuum. It moves from social care to health care, back to social care. It's very difficult to, make a distinction between the two. While having a public health background, my focus was on health, but I realized that I can't look only at health. One has to look at social care also. And that's when we realized about interministerial collaboration. Apart from the ministries that we've discussed, we also need to engage with the Ministry of Social Justice and Empowerment, where the whole elderly issue lies. And also, when we look at care providers, then the Ministry of Skill Development and Entrepreneurship, because they have the sector council, the skill sector councils. There is one healthcare sector skill council, which certifies courses for care providers, home health aides, geriatric care aides. So that is another area we are exploring that. We've done some work and hope to do more on that, which is also very related to the care for elderly. Because there are several issues around it. There are no standards, there are no set processes as to how does one deliver care at home, whether social care or health care. So right now it's more like a free-for-all. So I'll be happy to share some studies that we've done in the group if there is any such scope. Thank you.
We have 10 more minutes. Unless one of the panelists want to respond to any of the interventions till now, we'll continue with the questions, please.
Hi, I'm Dr. Sona. I work with People to People Health Foundation. I'm sorry, did I skip the queue? I think somebody else was supposed to say. So thank you for inviting, and thank you, Shoba, for sharing this presentation. So there are 3 take-home messages which I'm going to take today. So People to People Health Foundation works in NCD from last 10 years, and we are revising our strategy and evolving as the trajectory of government is going in the NCD program. So first takeaway is when we sit in this hall and when we look at the secondary literature, and one of the very unique perspective, we are looking at what Mona said, India aging, NCD raging. Okay, so this is an invitation from PPHF. Any scholar who wants to get a ground reality, a ground check, if you want to just come to the field. So we have currently 5 sites active in India. We have in Pune, we have in Gurgaon, and we have in Bangalore. So which also good mix of rural, urban, peri-urban. So anybody would like to come see what is going in the ground. You want to plan, a small intervention. You want to just see the effect, how things are going, or how you want to incorporate. Because government doesn't only have NP-NCD, it does have a national elderly care program, right? So anybody wants to have interest in, looking at the integration at block level. Because as Sir has currently identified, the strategy has gone from district to block, and we are trying to come up with multiple model and practical intervention which can be looked at a pilot but can take at a sustainability mode and scalability mode. So, and the third point is, when we say that MCH and NCD, so one more thing, you said about menopause, right? So I think this is again a very good takeaway message for us when we are designing another pilot intervention. So currently the whole focus of Government of India and the program is cervical cancer, breast cancer. That's what the women are looked after when we look from the NP-NCD lens, right? But then nobody is still looking at CVDs. ECG woman ka nahi nikalta. Are you getting my point? It's very easy to get the ECG done of men in the clinic, not the woman. So this also gives a lot of thought, food of thought for us, that how we can even, break. This is a barrier for me to make ECG. So this is not a very standard test, but still ECG can work a lot to ensure and to see whether the woman is having in a high risk category or not. So I'll end with the invitation, and thank you so much for inviting. So any on-ground experience, practical things, you are more than welcome, and I'm ready to host you. Thank you.
Good afternoon, everyone.
Charanjit Batra, I'm in health insurance. मेरा एक सिंपल ही क्वेश्चन है, बिकॉज फीमेल्स के अंदर इतना डिजीज़ काफ़ी ज़्यादा पाई जाती है, लाइक कैंसर, एनीमिया और डायबिटिक के जैसे आप बात कर रहे हैं. तो ये चाइल्ड, जब गर्ल चाइल्ड का बॉर्न होता है, बॉर्न के समय ये हम क्योर क्यों नहीं कर सकते हैं कि फ्यूचर में उनको ये फेज़ ना करना पड़े. और इवन आफ्टर मैरिज और बिफोर मैरिज फीमेल सेगमेंट में उनको बहुत ज़्यादा काम करना पड़ता है. लाइक जैसे वह एक्सरसाइज की बात कर रहे थे, मेडिटेशंस की बात कर रहे थे, वो ऑलरेडी इतना काम करती हैं घर का भी, और आफ्टर चाइल्ड बर्थ जो है उनको काफ़ी सारी रिस्पॉन्सिबिलिटीज़ होती है. उसके बावजूद भी उनको ये बीमारियाँ इतनी ज़्यादा क्यों होती है? और प्लस ओल्ड एज के अंदर तो बेसिकली ये है ही कि कैल्शियम कम हो जाता है, डिजीज़ काफ़ी ज़्यादा होती है, जॉइंट पेन्स काफ़ी ज़्यादा रहते हैं. लेकिन ये यंगर एज में भी काफ़ी ज़्यादा हो रहा है, कैंसर एंड ऑल डिजीजेस. प्लस मेरा बेसिकली यही है कि ऐसा क्या करा जाए कि जिससे कि आपके न्यूट्रिशियस जो है वो सॉलिड हो जाए फ्रॉम द चाइल्ड जब बॉर्न होता है, क्योंकि उनको फीमेल्स को ऑलरेडी मालूम है, मैरिड फीमेल को, कि किस तरीके से बेसिकली उनको नरिश करना चाहिए सो डैट कि उनको आगे फ्यूचर में फेस ना करना पड़े.
I think this is where I was talking about meaningful engagement of women. These are cultural barriers. Right from an early age, we have brought in the PNDT Act. It does prohibit that people will ensure there is no sex selection of the fetus. But at the same time, once a girl child is born, the priority given to a girl or her health issues is the lowest in the family. And that is something, again, which is very cultural, very society and the upbringing of the family. And we have to work with communities, with villages, with families. And that is where we want, women to take lead in such programs. And meaningfully engaging them means we have to give them leadership positions. And to be able to do it, we need to train, we need to empower them. So we don't have those curriculums, we don't have those training programs of how to meaningfully engage these women so that this upliftment and this whole society change can happen. And I would like to introduce PHFI is part of one consortium, which is the Healthy India Alliance. It is the India NCD Alliance, and Radhika is here. She is coordinating that alliance. That works very strongly on meaningful engagement. In fact, the advocacy agenda released by the Healthy India Alliance on meaningful engagement of people living with NCDs is now part of the revised NP-NCD guidelines. So that was the result of, constantly giving out the agenda and talking to government to be able to include people first and have people-centered programming under NP-NCD. So that could be one platform where women-specific and women-focused agenda can be brought up.
I think जो आपने बात पूछी वो final outcome of everything that everybody needs to do है. तो वो स्पेसिफिकली इस पर्टिकुलर एजेंडा और इस पर्टिकुलर पेपर और इस पर्टिकुलर टॉपिक से ही टोटली लिंक्ड नहीं है. उसमें जैसे डॉक्टर मोना ने कहा, होल ऑफ सोसाइटी को आना पड़ेगा, मेल डोमिनेंस को चेंज करना पड़ेगा, डाउरी लॉज को चेंज करना पड़ेगा, सेक्स सिलेक्शन बर्थ्स को, मतलब इट विल बी समथिंग दैट विल नीड द होल सोसाइटी टू चेंज. And but I think there are parts of India where we are seeing that. Some parts of Northeast, some parts of the south of India, we are seeing it happen. And but yes, I mean it's a big issue that you're raising.
It's not just the way you treat your boy and girl, the way you treat yourself as a woman. You put yourself last in the priority of the family.
Self-care becomes equated.
Thank you. Good afternoon, everyone. It was a very nice presentation. Thank you. I just want to ask, there were very close data that we saw between the male and female numbers. Were they statistically significant?
Statistical analysis
Would be useful to interpret,
yes.
because, and also that, and was there, when you looked at the sample size, was it done scientifically?
Yeah, this is the LASI data. I think it's the nationwide data. What was the number? So like, 73,000.
Okay,
It was
and second
proportionate
question
data.
I had for you was, like all the risk factors indicators were highly skewed towards the male, but whereas all your data suspects that the numbers are skewed towards females. What could be the reason? And in general, when we look at the numbers, we are tempted to assume that they would be favoring more NCDs towards the male population. What could be the reason you think that explains that?
I think probably the behavior and the risk factors in men than women. I think I can probably think of that as a reason. But yeah, the data did suggest that the numbers were, the risk and the prevalence was more in women. But yeah, definitely the risk factors in terms of especially smoking and tobacco was more seen in men. But definitely the prevalence of NCDs were falling more on the women. It could be also associated with the other factors, other social determinants, which have a multiple, like we said, it's a multiple factor which are responsible for the increase of NCDs in women. So probably it could be the other factors which have also...
Essentially, when you look at aging, you basically look at senescence, right? Cellular senescence is the key driver for aging. And also now is considered, senescence is considered as one of the key drivers for all the NCDs also. So in that sense, stress and other related factors plays a very important role in triggering cellular senescence. So have you thought about incorporating something on that lines?
Oh, no, sir. This was purely done on whatever the data was available. if you have some stress level test and those data are available, we could have correlated it with the...
Yeah, a lot of blood-related parameters can be considered. Definitely. So that could help in, determining the... but I think this is interesting, but it bucks the trend that the risk factors that has been there for a long time.
That's the limitation, sir. Whatever data was available, we could be able to,
last question
what was the trend, yeah.
In general, it is considered the females are more susceptible to respiratory disorders, non-NCDs. Have you considered, because your data does not include the respiratory diseases like asthma and COPD, but whereas females are considered like 50% more susceptible to respiratory diseases. Have you thought of? We have not studied that data. Thank you.
Thank you. Dr. Tandon has to leave, so I would request, I'm sorry we have to cut it short, but can we shift this discussion to tea and coffee in the adjacent room? Thank you so very much, Dr. Tandon, Professor Arora, for speaking. And thank you everyone. As soon as the LASI second phase data or reports are available, we'll reach out to you. And in the meantime, if you want to write about any of these issues and share with us, please go to the writing guidelines on our website. And please feel free to submit your articles to us. We'll be very happy to run it through our publication process, screening process, editing, and then carry them. Thank you so much.